thank uh, NH Cancer Collegium for Oncology Collegium for providing me the opportunity. So I am standing between you and the Saturday dinner. I'm sorry for that. I'll quickly rush through after a very extensive discussion. The panel I was hearing, even though they were bounces for me. So let me finish it in 10 minutes. In the coming 10 minutes, I will discuss on what are the recent developments as far as the PI3K targeting in a hormone receptor positive HER2 negative breast cancer. So, if you look into metastatic breast cancer, if you look into the hormone receptor positive breast cancer, we know that this is a slowly proliferating disease, and these patients are going to live longer than the other subgroups. They're little lower grade diseases, little more benign, confined more to bone, less to viscera. So this is how the biology is all about. So what we had was we were just targeting these hormone receptor positive with only letrozole or aromatase inhibitors or estrogen receptor blockers. But now what we've realized is if you're using only a hormone receptor blocker, the progression-free interval will be less than a year. So if you want to improve the progression-free interval and also the overall survival, we need to do something more, and that is the CDK4/6 inhibition. So it is a CDK4/6 activation that uh, reduces the activity. It phosphorylates the retinoblastoma protein activity and causes cell proliferation. So if you can inhibit the CDK4/6 activity, you can delay or even you can reduce the endocrine resistance. So with this background, CDK4/6 has come in a big way and has become an intrinsic part of treatment for hormone receptor positive metastatic breast cancer. So for any metastatic disease, for example, what is the important endpoint is how long the patient lives and how well the patient lives. It is not just the quantity, but also the quality of treatment and the quality of life that is very important. So we need to have a treatment in a metastatic disease which is not toxic, has a good quality of life, but with an improved overall survival. So in such a disease where the patient will receive multiple lines of therapy, starting from aromatase inhibitor to a estrogen receptor antagonist to exemestane, that is a mTOR inhibitor pathway where multiple further treatments and chemotherapies are there, getting an overall survival benefit where there is a lot of subsequent treatment is extremely difficult, and we have not seen it for a long time. For last 25 years, we have hardly seen any overall survival difference. Even though there is a progression-free survival difference, it has not translated to OS benefit. But now with the advent of CDK4/6 blockers, even though there is a crossover in subsequent lines, what we are seeing is a staggering overall survival benefit. So we basically have the three CDK4/6 inhibitors, right, starting from palbociclib, and then we have ribociclib and abemaciclib coming just now. So we have a very impressive overall survival data with ribociclib, both in the postmenopausal and in the premenopausal setting. So what matters is how long the patient lives. It really matters. So overall survival improves only if the drug is really effective. And these are the Mona Lisa group of trials. So the moment we say Mona Lisa, it addresses ribociclib trials. We have Paloma for palbociclib and we have Monarch for abemaciclib based trials. So here we can see the two randomized trials, the Mona Lisa 3 and the Mona Lisa 7, where uh, um, ribociclib has been used in combination with fulvestrant in Mona Lisa 3 in the postmenopausal population, whereas in the pre and perimenopausal population, the partner has been aromatase inhibitor or tamoxifen. So what we can understand from this slide is that we have evidence for using Quixana, that is ribociclib, with all the endocrine partners. You take fulvestrant, you take tamoxifen, you take aromatase inhibitor, which we don't have much evidence with other CDK4/6 blockers. For example, if you look into the first line usage of fulvestrant plus ribociclib. We don't have this evidence with other CDK4/6 inhibitors. You can see the magnitude of uh, uh, the patients enrolled both in first and second line with fulvestrant, and you can see the difficult biology disease like visible disease in nearly 60% patients have been enrolled in these trials. So, ribociclib is one of the unique CDK4/6 blockers which has evidence specifically to address the pre and perimenopausal subgroup and first line fulvestrant. The data is only with ribociclib. And if you look into the event-free probability or the progression-free survival and the overall survival, both are statistically significant, and you can see the hazard ratio of 0.72, which we hardly see in a metastatic breast cancer unless the modality is really effective. What you can note is the early and a persistent separation of curves even on longer follow-up. So, statistically significant improvement in median overall survival, nearly crossing more than 4 years, is what we can see here, is really staggering in a stage 4 hormone receptor positive breast cancer with a very impressive hazard ratio. So the overall survival also was improved in the difficult. So basically, the premenopausal and the perimenopausal have a little aggressive disease to treat. They present with advanced disease, faster proliferating disease, little lesser luminal A types. So even in this difficult to treat population, you can see the overall survival difference. Mark that the overall survival separates in the later part when compared to the Mona Lisa 3, where it was an early separation. And here again, you can see the overall survival nearly crossing 4 years. So, with this impressive improvement in overall survival in different patient populations in both Mona Lisa and Mona Lisa 7, so now we have ribociclib being handy and with lesser side effects. If we have a peri or a premenopausal woman or a postmenopausal woman who has had a prior aromatase inhibitor therapy, ribociclib with a hormonal therapy should be the treatment of choice. So it is not just how long the patient lives, it is how well the patient lives. So you can see the improvement in quality of life scores right from the pain scores, fatigue, and there is not much deterioration in the quality of life. So when we are giving any drug for a longer period of time, we need the drug to be safe and should not cause much side effects, and that is what we have with CDK4/6 inhibitors. So what? So having said that, if I'm using only a hormonal agent, I would have a PFS of less than a year. If I put a CDK4/6, with that I can have around 1.5 to 2 years. And after that, what? So this is the gray area where we didn't have an answer. What post
Yeah,
CDK4/6 should I
long
go for
long
chemotherapy
time.
or do I have anything? And this is what we have in the present day. The PI3K kinase mutations, which is present in nearly 40% patients of hormone receptor positive breast cancer, which is really a significant number you can see. So very important with these mutation is it's a biomarker. It's not only prognostic but also it is predictive. So those patients who have a PIK3CA mutation have an inherent resistance to endocrine therapy, and they have a shorter progression-free interval. So we can see that in a meta-analysis, as it was analyzed, you can see PIK3CA mutation being a potential prognostic indicator where they would have had a inherent endocrine resistance and a shorter progression-free interval. And this is how it is. A PIK3CA mutation causes higher cell
Yes.
proliferation, tumorigenesis, poor prognosis, and has an endocrine resistance. So PIK3CA mutation is not just prognostic but also predictive of therapy. So we had a lot of PIK3CA inhibitors. The problem with PIK3CA inhibition is that it if you inhibit all the isoforms of PI3 kinase, then the toxicity is too much. PI3K inhibition, if you can inhibit only the alpha isoform, then it is feasible and it is easily tolerable. So that is the uniqueness of alpelisib, which is a novel PI3K inhibitor, where we have, and if we can pick up PI3K mutation in nearly 40% patients, what we can find is if we can expose these patients to this PI3K alpha isoform, we have a significant progression-free survival benefit. So this is the Solar One trial where we have randomized patients who were postmenopausal women who had progression on prior aromatase inhibitor, and PIK3CA mutation was identified, and the randomization was 1:1 to fulvestrant plus alpelisib. You can see the dose of alpelisib 300 milligram once a day versus fulvestrant plus placebo, and the primary endpoint was progression-free survival. Remember, PIK3CA mutation was a biomarker in this particular study. So in those patients in whom they found a PIK3CA either on the tissue or in the blood, you could see an impressive difference in the difficult to treat population with PIK3CA mutation. You can see 5.7 versus 11 months, nearly doubling of progression-free survival if I can expose these patients to alpelisib. And you can see all the subgroups, whether it was visceral mets, whether it was bone-only mets, prior CDK treatment, prior chemotherapy, line of advanced anti-cancer therapy, endocrine status, all did benefit with PIK3CA inhibitor. Again, you can see an impressive difference in the overall response rates. Again, more than doubling of response rates if I can put alpelisib in combination with fulvestrant in the second line. So again, slide showing an impressive response rate and shrinking of tumor. And this is the way we dose at 300 milligram. So we have 2 tablets of 150 milligram taken orally with food, and the fulvestrant dose, as we know, first 3 doses 2 weekly and then monthly doses. And what is important with the alpelisib is its on target effect, and the class effect is hyperglycemia. So this is how it causes hyperglycemia. It basically prevents glucose uptake by reducing the glucose uptake receptors. So and that's the reason why it's an on-target side effect of alpelisib. So a very unique thing about alpelisib is alpelisib-induced hyperglycemia is quite more sensitive to metformin than the garden variety of diabetes, what we find. Uh, so these are the guidelines how to handle the hyperglycemia due to alpelisib, right from the diet modification to using metformin, and then in desperate situations to use insulin to maintain the dose intensity and density of alpelisib. So lifestyle changes are equally important along with medications for managing hyperglycemia. So uh, this problem with hyperglycemia basically happens in the initial 2 to 4 weeks, and once you have got a hang on its dose, then the frequency of monitoring can be reduced and the hyperglycemia incidence reduces. And rash is another issue, but if you can prophylactically use antihistaminics or supportive medications to reduce the rash prophylactically, again, the incidence of rash can be significantly reduced. So when to test PIK3CA mutation in any patient who is ER positive and HER2 negative, advanced breast cancer, we can test for PIK3CA. We can test either on the archived specimen or on the metastatic new biopsy or in the blood. So all are approved for testing. So tumor biopsy preferred, new fresh tumor biopsy, if not a liquid biopsy, is also preferred. In both these subgroup of population, there has been an impressive progression-free survival benefit with alpelisib plus fulvestrant therapy. So to finish off and summarize, so CDK4/6 is the way to go. You must have all patients being exposed to CDK4/6 inhibitor in all hormone risks, because it adds life to patient, preserving quality of life. And in those difficult to treat population, we must do PIK3CA mutation analysis either in the blood or in the tissue for all hormone receptor positive metastatic breast cancer, and we would be able to find this in nearly 40% patients. And in these otherwise who progress sooner, if we can expose them to these potential PIK3CA inhibitors, especially alpelisib, we can add life to the patient. We have an impressive progression-free survival, which is really doubled when compared to the placebo. So the take-home message is we must do PIK3CA mutation in all patients with metastatic breast cancer in order to improve the PFS1 and then the PFS2 and finally adding life to the patient. So regarding the toxicity profile of alpelisib, hyperglycemia is a class side effect and it can be easily managed if we can monitor it well in the first 2 months, then handle it with metformin, lifestyle modification, and accordingly, once we fix the dose, we can continue this for quite long, and it is easily handled. So, with this, I would complete my presentation, and I would again thank the Collegium for providing the opportunity, and thanks for patient listening. Thank you.